Okay, I've started recording now for our afternoon lecture, and we're still missing a bunch, so I will check them in as we go. All right, so this afternoon, we're going to talk about valvular heart disease. Now, we talked about infective endocarditis on the inside. We've talked about pericarditis and rheumatic heart disease. This is valvular. Now, they could have had issues with the other things we've talked about, and that's what led them here. We'll look into it and see what we find. All right, so this is a great picture. I encourage you to download it. It's on Google Images, it's on Pinterest, it's on Bing, it's on any place you want to look for blood flow and valve images. And if you have at all an issue with how the blood flows through the heart, that it's unidirectional and everything about the valves and what controls what, this is a great visual for you to have. So I always start with this picture. If all you have is this one from your slides, you can certainly take a picture of it, but you can get it off of any search engine. And it's a great resource to remind you of which way blood flows and what I'm talking about. And I will refer, you can't really see it here, there's probably another example. I will keep referring to the inside of your aorta as it leaves the left ventricle, like right here. On the inside here is where you find these ostia, these little openings, you can't see this side, but on this side, and they go out and feed the surface of the heart. That's what we talk about when we're talking about coronary arteries. So it's a great picture if that helps you study. All right, so valvular disease. We define it always by the valve involved, which can be any one of them, your tricuspid pulmonic, your mitral aortic. But in adults, we see aortic and mitral. So those are the ones that we're going to focus on. And then it is described as its dysfunction. Is it a stenotic valve or does it regurgitate? The blood has to go one way through the heart. So is it stenotic and it's so tight it's not letting it go? Or is it regurging and letting it flop backwards and not carrying it forward, having trouble with it splashing back, not closing enough? Okay, so normally, revisit your knowledge of cardiac valves. You probably had it in A&P, you might have had it other places, maybe in 151. You probably had it in PEDS even with valves. So normally the pressure is equal on both sides of a valve. The blood comes in from your superior vena cava into your atria. That amount that goes into that atria is the same amount that goes into that right ventricle, that goes up your pulmonary artery, goes to the lungs, gets oxygenated, comes back in your left atria, goes into your left ventricle, and goes out to the aorta. It's all regulated, and that's how you have normal cardiac output, right? It's the same amount all the time. Okay, when there's a stenotic valve, the valve is narrowed, and the forward flow of blood is impaired. So when you have a stenotic aortic valve, you have all the blood in your left ventricle, and your left ventricle pumps it, and it's trying to get through this tiny little hole and get out because it's so stenotic, it's closing up. That doesn't work well. If you have regurg, you have an incomplete closure. So now your valve is floppy. And so it lets the blood out, that's fine, and then it goes to close, and it's not quite closed. So the blood can regurg back where it came from. And that does not support unidirectional flow of blood. So those are your classifications. So the general demographics, if you have valve disease in kids, it's congenital. It's something they were born with, and that's why they're dealing with it. In adults, you had to have grown up and had arteriosclerotic heart disease, you have to have an MI, you have to have something that affects your valves this way. It could be that you had AIDS, and it's either the spirochetes, the infections you're having, the fungal infections you're getting because you can't fend off, you don't have a functioning immune system, the medications you take, okay? It can be medications in general. Many times over history, we've had a problem with this. The great example always comes to mind is fen-phen. This is phentermine, fenfluramine, and this was a drug, a weight loss drug that came out, I don't know if it was mid-'80s, it was certainly late 80s, and it was off the market by mid to late 90s. So this is a case where, they are anorectic drugs. These are two drugs they combine. They're both powerful anorectic drugs. So they were for morbidly obese people, and they took the drug, and it helped them, it suppressed their appetite, and it was working on chemicals that made them have no interest in appetite at all, no hunger. These people, the fat melted off of them. I mean, it went off like nothing. So it had been in FDA trials and it was looking so promising, they released it. It comes out and then we find people are developing aortic stenosis and pulmonary hypertension, and it's off the market. So you can't get fen-phen. Phentermine is still out there, and that's a drug that's used, and that's fine. It doesn't show any problems, but it was with fenfluramine, so they called it fen-phen was the drug, and it's off the market for weight loss. And many, many people who unfortunately had been morbidly obese, lost so much weight and felt great, had to go in and have aortic valve replacement. So not a good consequence of that. Okay, so aortic stenosis and microregurg are going to be common with those aging adults I talked about. As you age, your valves don't work as well. They start to fray, and they're just fragile like everything else. Like your cartilage gives out, your valves can give out. And because of that, as these people get older, they get more prone to these problems and end up having surgery. All right, so let's talk stenosis first. Mitral valve stenosis. The most common cases are rheumatic heart disease. Now, we see less of it now, so you won't see that much of it, but you will see it in the older population, because those are the people that would have had some rheumatoid, rheumatic fever, some rheumatoid sequela related to it. So the other things, it can be congenital. Some people, the leaflets are that way when they're born, and it's something they've watched their whole life, and they get into adulthood, and now you're having real issues. It can be, of course, the rheumatoid factor, and in with that becomes diseases like systemic lupus that can affect any tissue in the body and can cause real issues for your mitral valve. So the rheumatic endocarditis that we talked about causes scarring, right? So the leaflets, the chordae, the papillary muscles, everything gets affected by this. So now they're not flowing and opening and closing valves like they should. They get thickened and shortened, and they obstruct the blood flow going forward. They get really stenotic, and that's a problem. I mean, your blood has got to flow in one direction. Okay, so what happens? The pressure difference between your left atrium and your left ventricle during diastole is an issue. So your left atrial pressure, blood has come from your vena cava into your right atrium, down to your right ventricle, out to your pulmonary artery, to your lungs. It gets oxygenated, it comes back into your left atrium, and then into the left ventricle, right? So left atrial pressure and filling is increased because the valve is stenotic, and it should be opening and let the blood come out of it. And instead it's, if it's open this much, which of course it's not, it's so much smaller, but if it's open this much, it's opening this much. So the blood isn't getting out. So that is trapping blood up in your left atria. That filling pressure is increasing. The filling of the atria itself is increasing. So that is going to back up to where it came from, which is your pulmonary capillary bed. So now you have increased vascular pressure in your lungs, in the circulation where you exchange, where you perfuse your capillary beds in your lung. That's a problem. You have hypertrophy of those pulmonary vessels. What are they going to do with this blood? Every heartbeat is giving us more blood to push forward. And we have a stenotic mitral valve, and it can't get out on the other end. So what's happening? It's backing up. And how do we see that? So of course they have an increased risk of atrial fibrillation because you have a dilating left atria, and it's going to get irritable because it's being stretched beyond its capacity. You have hypertrophy of the pulmonary vessels, so we're going to start seeing pulmonary involvement. So long-term, you see increased pressure that is going to eventually lead to a right-sided heart failure. Eventually, if you do not correct a left-sided issue, it's going to back up to the right side. The pressure eventually will be all the way over the other way. The blood is not moving forward well enough. So let's look at this a little more closely. Here's what you see. Here's our graphic. So here, let's say, is your normal left atria. So the blood is coming in from the heart. That's why it's bright red. It's been oxygenated. and it comes in here, and this should open this wide to get that set amount of blood out of the atria into the ventricle. The ventricle's waiting for it to fill. The next pump, we're relying on this aortic valve to open and send blood out to the system, right? So this one opens, should be opening like this, and instead it opens like this. So now you have a buildup in pressure in here, and you have a buildup in filling. This is going to give over time. It doesn't do well when it has to give immediately. So this will build over time, start stretching. You see it's bigger than this one. This makes this atrial muscle irritable, and that's where you get those irritable foci from that you start getting AFib. So when somebody comes in for AFib, they don't just say, oh, AFib, older person, a lot of them have it. No, they have to look to the etiology. Do you have a problem with your mitral valve? Is this what we're looking at? Did you infarct and have an issue? Did you, what is it that's causing this? You don't just develop it overnight for nothing. So what do they have? They have fatigue, because are you getting your same volume? No, you have a lower cardiac output. If all of this volume that should be in this ventricle is not, then what's in this ventricle going out to this aorta is less. So the people are tired. Now, as far as heart sounds go, you know your S1, S2. I told you you don't have to know anything else. Here is a loud S1. So you're used to your lub-dub, lub-lub. Now it's lub-dub. I mean, it's loud. It's significant. So while you'll recognize S1, S2, you'll see it's different. A diastolic murmur comes with it. Don't worry about it. That's a, vibratory thing, and you don't have to worry about that at this point. Hemoptysis. Why is your patient getting hemoptysis? Think about this. Why does this make sense? Because when the blood coming from the lung can't flow freely into this atria and come down into the ventricle, so much of it's trapped up here. This has a limited capacity. Where is it pushing back to? It's pushing back to your capillary beds. So now your patient is all the time. And sometimes it'll get moist when it gets really bad. And now they're coughing and you see hemoptysis. They have bloody sputum. Okay, they can have chest pain. Why is this? Because what do I tell you? This blood comes out of this atria. It should, in full capacity, come into this ventricle. And when it comes up here and this aortic valve opens, this will feed the ostia that are here and here. We still can't see it in this picture, here and here, roundaboutly. And when the blood, as much as it's going up here to the aortic arch to feed your carotids and your subclavians, feed your brain, it's also going out the aorta to feed the body. But one of the first things it does is stop and feed the coronary arteries. So now you have less blood coming out of your ventricle, you have less blood going up to the aorta, you have less blood going up to the brain, but you also have less blood that could be going into the ostia, the coronary ostia, to feed them. So as a result, your patient will have chest pain. AFib on an EKG, with that comes the palpitations your patient will tell you about and the risk of stroke. Remember, your atria fibrillating, they're vibrating back and forth. If you have atherosclerotic plaque in there, you're sending it off. It increases your risk of stroke. Okay. Here's mitral valve regurg. This is the opposite, okay? All right, so this is an incomplete closure now. This is different. Most often this is your MI, which is why you have to watch them. MIs are not stable. Let's not forget they have infarcted the powerful muscle in the body that's keeping everything going. So when it's infarcted, there's a problem. Okay, other causes, again, into the rheumatic diseases, a mitral valve prolapse. We'll talk about prolapses. They're pretty much benign, but if you have an infarct and the area you infarct impacts your mitral valve and you already had a prolapse, it could compound that. You could end up with some trouble. Otherwise, ischemic papillary muscle. People don't think about this, but if you infarct where the blood supply is for your papillary muscles that control the work of your valves, then you have a weakened valve muscle. And so your valve is not going to work as strongly. So this is your post-MI patient you see this in. And infective endocarditis. So don't take lightly your IE patient. Don't take them lightly. You'd be surprised. They can end up with mitral regurg. All right, so what happens here? Let's look at our picture. So here you have a backflow of blood from the ventricle. Here, the blood is coming from the lung. It comes into the right atria, and the right atria dumps the set amount into your ventricle. But now this gatekeeper is lazy. It's floppy. So this left ventricle is a powerful muscle, and it contracts to send blood out to the body that is waiting for it. And what happens? Some of it comes this way, but some of it splashes up in here. So that's a regurg. We don't need that. Your atria doesn't need it either. The blood is trying to come unidirectionally in one direction. And now your mitral valve is getting floppy and it's acting up. Now your right atria, your left atria is subjected to the pressure of the ventricle, that big contraction sending it back the other way. So the atria is not happy with that, nor is your lung, So both chambers are overworked trying to maintain cardiac output. Because through all of this are your mechanisms in your body that say, we have to maintain cardiac output. Did our cardiac output drop? Let me send out a neuroendocrine hormone. Let me respond, the beta receptor will pick it up and stimulate, and you'll have tachycardia now. So what do we have? We have the heart trying to beat faster, but we have blood that's coming. It doesn't help us because the blood keeps coming, but it keeps splashing back. We're not getting a full complement of blood out to the aorta, out to the body. Okay, keep that picture in your head. So you can have acute and chronic MVR. Acute is your MI guy. This is a guy that, he's the chambers. There's no time for that chamber to accommodate. There is no time for the atria to learn, okay, what do we do to compensate for this? Hold on just a minute. No, the patient, boom, has infarcted. It's affected the integrity of the mitral valve, and it's not working well. So this guy gets bad real quick. The increased pressure and volume into the pulmonary bed makes them react because you've just had an infarct. You have muscle that isn't pumping well in your heart to begin with. And the body's trying to compensate. But now we have all this backsplash of blood and the lungs are saying, hold on, too much here. They have pulmonary edema, which is a rapid onset. They can go right into cardiogenic shock because they are not perfusing. They're not doing well. Your body is waiting for the aorta to give it blood. That's oxygenated blood that has come in your left atria into your left ventricle. The body needs it. And now every time compression comes, half of the blood is going back up to your atrium, which is now putting pressure on your capillary bed in your lung, and the body is not getting what it needs, which means your cardiac output is decreased. Low cardiac output is going to increase stimulation of neuroendocrine hormones, right? We talked about that with adrenal glands. So it's going to start your patient diaphoretic and all of that. The pulmonary edema, now they're having trouble with oxygenation and they're having trouble. This patient goes bad real quick. So there's no time to accommodate with acute MVR. Chronic, this is different. So maybe your mitral valve was a little sketchy. Maybe over time you had something developmentally, whatever it was, age-related. It's now a little shoddy, your valve, whatever. And over time, they've seen signs of it. They probably picked up a subtle murmur, doctor's been watching it, whatever. So they can do gradually, your atria is getting used to the fact that it doesn't quite shut. And then it's shutting less. And then it's shutting less. So there's a gradual accommodation. They do end up in the same state that there's a decreased cardiac output, but there's been some time for the heart to adjust to it. And your body's pretty good at compensating. So over time, it's kind of adjusted to a little too much filling pressure in the left atria. All right, so what do you see in the acute MVR patient? Well, they're cold, they're clammy, they have a thready pulse. That's those neuroendocrines coming to save you. So boom, the beta response, and here it comes, and you get increased heart rate because that will increase cardiac output. Okay, the body's trying, but it's increasing your heart rate, which is going to make you breathe faster. You're having trouble breathing anyway. You have low cardiac output. If we don't recognize this and treat this patient for repair or replacement, you lose this patient quickly. They'll just code and die on you. They got to go. Now, you work in a coronary ICU. You're watching for things like this. You get it. You understand it. You know it's coming. Everyone's got their eye out for it. So, but you have to be assessing your patient. And not to say you're not going to be down in the ED when a big MI comes through and this couldn't be happening before your eyes. It could be. So you got to pay attention. Watch your patient. Pay attention to what the body's telling you. It's important. Okay. Chronic.
Hey, Jane.
Sure. Go ahead.
Are you saying that an MI will cause this, or this causes an MI?
No, an MI will cause this. You can have,
Okay, thank you.
you can have other reasons behind it that we talked about, you know, rheumatic disease, chronic illness, whatever. You've had, you know, bouts of endocarditis and things that have affected the valve. But your acute MVR is your MI patient. Yeah, because the area where they infarcted is what's supplying your muscles. Yeah, and you have ischemic papillary muscles. Okay, so your chronic, generally they're asymptomatic for a long time. But the first signs, I mean, some doctor is on it, they're seeing, because they had to have had something, unless it's just age, unless it's your 90-year-old person that, God bless them, is, you know, has been fine all this time and is now showing some signs. But otherwise, the first signs are the weakness, the fatigue, palpitations, brings an old person into the doctor. My heart's just fluttering. So they go looking for the causative agent. They are dyspnea. They do have dyspneic. They have dyspnea. They are orthopnic. So those are the same patients we're saying, so how do you sleep at night? Do you sleep flat in the bed, one pillow? And they say, oh no, I sit in a recliner. Okay, your clot is thickening. What do they tell you? They're orthopnic. They have to sit up. Even outside people figure that out, and they sit in a recliner in the den. So peripheral edema that they never had. So we're looking at that. Is it kidneys? They'll do kidney panels. Is it this? Is it that? We don't know. It could be a bunch of things, but if they're tachycardic trying to compensate, they'll tend to get peripheral edema. So even the increased left ventricular filling causes this extra heart sound. Even if it's functioning okay, because the chambers are under duress, you get an extra heart sound. So you're listening to your patient, you're used to hearing the patient looks okay, they've been doing okay. You listen and you have an extra heart sound. You're like, I got an S1, S2, and I got something else. So that's another clue for you. Okay, so what's the treatment? Acute MVR, they need intervention. They won't survive. You gotta get in there, and they can try and repair it. Most times they go in and replace it, because it's a big enough surgery to go in and try and repair it. And if the repair isn't good enough, you're back in there again. So if they think the person can tolerate the surgery, and they have, mind you, it's usually someone who's had a fresh MI. So they're not always the most hemodynamically stable person on the planet, but if they think you can withstand the surgery, they'll just replace it. The patients with chronic are gonna be watched closely. Medically compliant, keep your beta blocker meds, keep whatever blood pressure meds the doctor gives you, stick on your diuretics if that's what they give you, you know, keep up your gradual motion, your exercise regimen, whatever they've had you do that's working for you. But eventually they'll develop left ventricular failure. Eventually they will. And they'll have signs of pulmonary hypertension, and they'll have the cough and the hemoptysis and all of that. So shortness of breath and dyspnea and all. So then they'll take them in for intervention. Okay, so mitral valve prolapse, I mentioned this, and mitral valve prolapse is pretty much a benign thing. They used to say in the articles when you read it, typically every young girl in America has a mitral valve prolapse. I don't think it's that prevalent, but it is kind of prevalent. And all it is that the leaflets are prolapsing back in your mitral valve, but they still close correctly. So they might bubble back. They might be like a sail with wind hitting it, you know, that kind of puffs out a little bit, but it doesn't interfere with the function of the valve. So it really isn't that big a deal. Now, if you end up with papillary muscle infarction or something from an MI, and that's the area it hits you, that might be a problem. You already have this prolapsy kind of, you know, valve that kind of balloons, but now maybe the gait isn't working too good and now it's a little more floppier. That could give you a problem. It still works well. It's considered a benign condition. It can be serious in the setting of an MI, but it's usually not something they're going to intervene about. Now, some people will have issues with it. And it's one of these things that if we know you have a certain collagen disease or you've exhibited other collagen connective tissue-like issues, they're probably going to watch you and see if you develop something like this. But otherwise, you know, and people screen genetically now for like Marfan's or some of the big collagen diseases. So it's not usually that prevalent in people that we see it. Most people will not have a cardiac issue. I remember I was pregnant, I don't remember which child it was, but I was, the obstetrician was listening to my heart one time. And he said, I think I hear a murmur or something. And you know, obstetricians will pick it up because the mother's circulating volume is bigger. And so if it's gonna, you know, if you're gonna hear it, you're gonna hear it, and that they're a healthy woman otherwise. So he's listening and he said, you know, I'm gonna send you for an echo. I said, okay. So I never tell people when I'm in the hospital that I'm a nurse. I mean, sometimes it comes out because it'll come up in your record. Like I go to Pineville, it comes up, patient is employee, you know, so then everyone goes around, oh my gosh, she's an employee. And then all the nurses say, oh my God, it's my old teacher, you know, they all come flying in. But, you know, I don't offer it to people. So anyway, I'm in having this cardiac echo. And, you know, they move the little thing all around your chest and they have you move different ways and move your arm up and down. And they see if they can manipulate the valve at all, if it's changing. And so she has the volume up. Now, I'm not great at cardiac echoes, but I know what I'm listening for, you know. So I'm laying there and I hear love dub, love dub, love dub. And we're doing all these positions and it's love dubbing along. And I'm saying, well, thank God this is good. And all of a sudden I hear love dub, love dub. And I'm like, do I have a splash? I think I have a splash. So I said to her, do I have a splash? And she looks at me and she's like, she turns the volume down and she's like, who are you? What do you do? And I said, I thought I heard a splash. And she's like, I can't discuss any of this with you and, you know, this and that. So the bottom line was he was right. He heard something. It was good. But of course I had the baby and I don't have a splash anymore. So it had to be my circulating volume. And so what did they say? You probably have a little prolapse. And with the extra circulating volume, we picked up a splash. I mean, it was a hint of a splash. I've been down and because I'm interested, and if somebody's going down and I can go down, I go in and see what's going on. So I have something better to explain to students and all. So I've been down in echoes where someone has a real bad regurg, and it's like, you're listening for the love dub, and it's like whoosh, whoosh, whoosh. And I'm like, whoa, where is my sound in here even? I mean, we're talking a splash that is just completely ineffective. So my little splash didn't amount to much, but I heard it and it was enough for it just to come out, you know, and I have a pretty good game face, but I was like, is that a splash? I have a splash. And she's like, okay, calm down. Who are you? So most people will never have an issue with it. It's fine. The life expectancy is not affected. And even when I've changed doctors, gone for other appointments, they don't bat an eye when they see it. So. All right, so what do you see in people that are symptomatic? Well, you're not really going to see a lot of symptomatic people. If you get somebody, the numbers are very low, but they will have a murmur, and it doesn't go away after they're not pregnant like me, but it'll stay there. You know, they have a murmur, and it usually doesn't alter their S1, S2 functions, so everything's fine. And if they get under duress and the heart is beating fast to compensate, like some emergency or stress in their lives or something horrible they're going through, they can feel chest pain like tension, but the studies have shown it's not angina. What they're feeling is papillary muscle tension, because that's probably where their issue lies. So then they treat them palliatively. So what can we do? They try and decide exactly the kind of pain you're having. So they say, all right, tell me about when you have an episode. And they're like, oh my God, my child was hit by a car. I was out in the street and I thought, oh, I'm getting this chest pain. Where's it coming from? And they're like, okay, so you had a panic issue and this related intention and blah, blah. You know, they try and make a story out of it. And sometimes if the ambulance, they're out on the street with their child who was hit by a car and they say they have chest pain, they're going to throw you in an ambulance and take you in. So they come in, and if in the ambulance they give you a nitro or something and you have no relief from this pain you're feeling, then they know it's not that you're having angina or some kind of heart problem or whatever. Please God, they take your vital signs before that, so they're not giving you nitro if you seem to be doing otherwise okay. But So what happens then? Then they say what it is when your heart beats really fast, it's your papillary muscles that are reacting. So they either calm them down emotional distress wise, or if there's someone who experiences this in clusters periodically, they say, we'll give you a little dose of beta blocker. Because what are we doing? We're trying to tell those neuroendocrines, don't respond so quickly. Just chill a little bit and give this person a chance. So they might be on low dose beta blockers for that. We teach them, of course, the obvious, don't drink caffeine, no Red Bulls, things like that are just full of stimuli when we're trying to get your stimulation to calm down. Stay hydrated, keep walking, do whatever you have to do to maintain a healthy heart, healthy diet, etc. And usually they're fine. Okay, so let's talk aortic stenosis. This poor soul, unfortunately, is not so good. So what is it? It's a stenosis, so it's narrowing of your aortic valve. Your aortic valve has a huge job to do. It regulates the flow of blood coming out of that, your biggest chamber in the heart, your left ventricle, and disseminating it out to the body. So it's got to be in good shape. It's got to be working. So this can be, a narrow one can be that you were born with valve issues and you will have multiple surgeries and whatnot your whole life. And it can be that. It can be, of course, the rheumatic fever. It can be degeneration. We're back to our elderly population again. And your generation of nurses will probably see a lot of this because what's going on now, they anticipate the silver tsunami. The baby boomer group is aging into their silver years. So with that, you see a large population of elderly on the cusp, and they tend to have what they call fibrocalcific disease. They used to call this senile coronary artery disease, meaning, not that you go crazy, but just that it happens as you're aging. It's a product of aging. Now they call it fibrocalcific disease, which is the same thing, but they think it's more palatable, a nicer word. So you'll hear it referred to that way, and it just means their valves are aging as they age. So rheumatic disease can cause fusion between the commissures. Commissures are the little pieces of valve, like 2 or 3 pieces that come together to make a valve, and the commissures get all tied up and stenotic. So we have to watch for that. So they look to see if you've had a rheumatic history and if that's an issue, because that'll give you obstructive outflow, eventually, and that'll require an aortic valve replacement. Okay, so demographically, 3% are over 65. So how many cases of this do we really see? I mean, that's 3% is not a huge bit of our population. But I always say to students, when we're looking at statistics, if you're one of that 3%, it's 100% to you. I mean, this matters to you. It's very mundane to your life. And you'd think, well, who do they do these aortic valve replacements on if they're old people and whatnot? This is the patient that, have you heard of somebody, a neighbor, a friend, a family member, a patient you had, somebody who's got a 93-year-old mother, and the doctor says they need an aortic valve replacement. And the family will say, do you believe they want to do open heart surgery on Granny, who's, this old little thing, the poor thing? You can't survive with aortic stenosis. It's got to be fixed. So if Granny is the type that still takes herself to church on Sundays and cooks her own meals and lives on her own, which there's plenty of them out there, then yeah, they're not being cruel to Granny. That's why they're doing this for Granny, because you don't want her to die of all this failure in the heart when it's not necessary. So if Granny's okay with it, everybody else should be okay with it, So that's why you see it. And every time I hear someone say, why would they do this to this 88-year-old person? Well, are they active? Well, yeah, they go on cruises, they do this, that, and the other thing. Well, they're going to die without it. You're going to let them die today, or you're going to try and replace the aortic valve. So that's what they look at. If you can tolerate the surgery, they're going to do it. Okay, now, isolated aortic stenosis is non-rheumatic. And that makes sense to you. Why does that make sense to me, Jane? I can hear you. Because rheumatic fever, when you get it, and it leads to your rheumatic heart disease, it's the whole inside of the heart, right? So you have mitral and aortic involvement. So if somebody presents with just aortic, then it's non-rheumatic. So we don't see that much. It's out there still. It's out there. And you'll see more in the silver tsunami, I'm sure. Okay, so here's your aortic stenosis graft. So you have this, the blood has gone out. They don't have ostia in this picture either. I will find a picture with ostia to show you. But, and you remember from anatomy, I bet. But anyway, blood comes from your lungs, coming in here into your atria. It's going to come down here. The mitral valve should close. This fills up in here. This valve should open, and all the blood should go up. Now, here's what I'm talking about, the branches on your aortic arch, right? Here's your brachiocephalic. Right above this, it breaks off into two vessels. One is your right subclavian, one is your right carotid. And then this is your left carotid, and this is your left subclavian. So as blood is pumping out here, not only does it come into these tiny little holes that you can't see and feed the surface of your heart muscle, but the blood comes up here and feeds your brain with these vessels and comes down this way and feeds the rest of your body, okay? So now we have stenosis. This valve is not opening like this. This valve is opening like this. So you have all this pressure in here. You have this big, thick muscle. See how this wall is and this interseptal wall? Big, thick muscle is pushing blood, and only this much is getting through. So you have less going in here to the ostia. You have less going up here to your aortic arch and less out to the body. So this patient's going to die if you don't fix this. So as the disease progresses, any kind of compensation fails, anything. So you have decreased cardiac output, which leads to decreased tissue perfusion, which is going to put your patient in cardiogenic shock. You have pulmonary hypertension, because the blood coming from this ventricle that's trying to get out through this valve can't do it. So where's it going to go? Let's try this door. Maybe I can get up through here and put pressure on the atria. Well, the atria has the next heartbeat with blood that's trying to come in, and it can't get in. So it pushes pressure back in the capillary beds again in your lung. So they get pulmonary hypertension and they go into heart failure. Your increased myocardial oxygen consumption is significant because this ventricle is working hard. This atria is under pressure. These ostia are not getting fed. The body's not getting fed. So we have a huge oxygen demand, and all the oxygenated blood with every heartbeat, and they come successively, is coming from the lung. All that oxygenated blood isn't getting anywhere. So this is not a good situation. This patient needs intervention. So we don't want the 88-year-old, the 90-year-old who still, carries a golf bag going to play golf on a Saturday, or still goes to the teeter and goes to church and whatnot. We don't want them dying like this. Okay, so what do you see? When the valve is about 1/3 in size, people get classic conditions. They get classic symptoms. So they all get angina, because the ostia are not getting fed. So the vasculature on the surface of the heart is not getting oxygenated blood. That's angina. You're going to have chest pain. So they get syncopal. Why? The blood going up to the aortic arch is less. You don't have oxygenated blood going to the brain. What happens? Change in level of consciousness. Whoop, person's on the floor. So they have exertional dyspnea because they have left ventricular failure. The left ventricle is trying. It cannot mobilize enough blood. It gets some through that little hole, but then the next beat is right upon it. And now it has more pressure and it's trying to get more and it's not working. And it's backing up and more heartbeats are coming until they're not going to come. The heart's not going to beat because the blood isn't moving. So that's a problem. The prognosis is very, very poor for symptomatic people. They have to go to the OR and get a replacement. Okay, so nitroglycerin is used very, very cautiously for this anginal pain. We know the etiology. We get the idea that the blood is not getting up into the aortic arch. It's not getting into the ostia. It's not feeding the blood supply to the heart muscle. They're not getting enough oxygenated blood. The patient has anginal pain. But think about it. Nitroglycerin is a vasodilator. You give them nitroglycerin, it systemically vasodilates, the pressure drops lower. Is that helping us? No, that's not helping. It causes low BP, and low BP is increasing the chest pain. So some doctors will say, we're going to use it, but just this much, or just give them this, or give them half a tab, or give them this. I mean, because it can really make matters worse. So you see the dire straits they're in. You can't leave them in an anginal episode that's never going to resolve itself. And the meds we use for angina can make it worse. So you have to be really, really careful. It's not one of those things you go to for angina, you know, that people normally do. They say, oh, angina, let's get some nitro under the tongue. Pay attention if this is your aortic stenosis patient. Gotta watch that. Okay, auscultation when you're listening. Soft S1. You're used to hearing your S1, S1. You're like, is my S1 there? It's real, real soft. Diminished, maybe you don't even hear an S2. And you're like, wait a minute, what's with this person's heart sounds? You know, and so you have a systolic murmur, which you don't need to worry about. It doesn't matter, but it comes part and parcel of this. Yeah. This is a sick patient. Okay, aortic valve regurg. This is the other way now, right? So this is backflow of blood from the aorta. What's happening now? This isn't good. We have blood that comes from the lung, all oxygenated. It's got to come into your left atrium. It's going to go down into the ventricle. And now the ventricle's pumping it. It's got to go up here. This aortic valve should open. It's going to feed the ostia inside here. It's going to go up here to the arch, send some to the brain, go out to the body, and everybody's happy. Except after that pump happens, the door needs to close so the ventricle can collect another set of blood, another pot of blood to send out. And it won't. It won't close tight enough, so some of the blood going up to the body comes splashing back down into the ventricle. So that's decreasing your cardiac output, right? And every time blood comes down, the next heartbeat is sending more blood in, like incoming, and you just can't keep up with the load. So it can be, now you have backload of pressure into your lung again, you're not getting cardiac output out. You know, this is a main gatekeeper in your aortic valve. So this is a problem when it regurges. Okay, usually we see it in, you know, again, you could have infarcted and really damaged your aortic valve. You could have had a procedure done, and in hooking something, they catch your aortic valve and damage it. You know, it's one of those things that you sign your life away when you have a procedure. That could happen, but. Okay, so acute and chronic again, here we go. The acute, this is trauma. So have they done some procedure to you and something's happened to your valve? Boom, you're in the middle of something and they're like, oh man, that just hooked this and now the aortic valve doesn't work. That's an acute episode. Is it that you've had infective endocarditis and now it's affecting your aortic valve? Because that, and people, you know, the ones that are saying, well, it's just an IEs on antibiotics, no problem. Now it's affecting your aortic valve and the patient's really in trouble. It can also be an aortic dissection. Now we talk about dissections when I do aneurysm. It's not an aneurysm, a dissection is different. You have multiple layers to an artery, you know, your interna, your media, your tunica. And what happens is there's a tear, usually from, it can be a procedure, but usually it's from arteriosclerotic plaque. And it wears away or breaks off and it causes a tear in the vessel wall. So as the blood is getting pumped out, it's going down a path between your inner wall and your medial wall, and the blood is collecting in there instead of going through your aorta out to the body. So that can be a situation also, and that's life-threatening as well. So the chronic one, again, we're looking for this in our person who has a history of rheumatic heart disease. You'll see them as little as we say they are in the public. If you work in a coronary unit, you'll see them because that's what's going to come to you. They're going to come in with their chronic problems and you'll see them in your unit. Someone who's had a congenital issue, you can have bicuspid issues, you can have anything that kids can be born with that structurally isn't right. They usually can't correct it completely, that it doesn't give them problems down the road, you know. People with syphilis. Now, syphilis is still alive and out there. And several people will say to me in past lectures, I didn't even think it was still around. It's around. It doesn't go away. The spirochetes get everywhere. So people that have syphilis, and the thing is, if you've had syphilis 15 years ago, sometimes 20 years ago, you can end up with a syphilitic aortitis 20 years later as you age. So it's something that people can't even foresee. A doctor will know, it's in your history, so they'll know you have a history of this and they need to watch for it, but yeah. So anyway, what else? The chronic rheumatic conditions. So even if you haven't had rheumatoid arthritis, but you have ankylosing spondylitis, or you have something else that comes with rheumatic conditions, you can still develop valve disease that relates to that. Reactive arthritis, I don't think we study that. I say that every semester. I didn't ask anybody. I don't know if we study that in this school or not, but it's a kind of arthritis people have who have autoimmune diseases. And let's say you have a flare of your ulcerative colitis, it flares your joints and all of that because it's rheumatic. So a chronic rheumatic condition like that, you'll see it. Okay, let's see. So what happens? Well, regurg, we talked, the blood flow goes back into the aorta during diastole and increases the volume in the ventricle, which isn't good. Ventricle doesn't like that either. The left ventricle will compensate. That wall will toughen because it's overworking, trying to say, what do you mean the blood didn't get out? Let's try it this time. I mean, it's working hard. It's increasing oxygen demand. But the muscle, by overworking, becomes hypertrophic. So you have an LVH, you have a left ventricular hypertrophy, and it gets dilated, but it's thick, really thick. Eventually, the left atrium backs up, pulmonary bed backs up. Where's it going to come? You have to know the unidirectional flow of blood so you know when it's interfered with, where it's coming from, where it's going to back up to. Okay? So eventually, you can end up with a chronic right-sided heart failure. We see less of that. We control it a little better now. Okay, so what do you do? Well, with acute aortic valve regurgitation, patients have sudden onset. Again, this is your MI person, boom. And they have sudden onset, cardiovascular collapse. You can't keep their BP up. You can't keep them perfusing. O2 levels are dropping. I mean, it's the left ventricle has this aortic pressure coming back at it. It can only do so much. And it has no time to compensate. It was fine a minute ago. You infarcted, boom, now look what's happening. So some of these people don't make it out from their MI for things like this. You know, we don't see it, and you don't maybe aren't as familiar with it because they had a massive MI and died, and it could have been related to this. So we don't know. Unless they do a postmortem, we don't know what happened in there. But they have severe dyspnea. They have horrible chest pain. They have hypotension because they have left ventricular failure. So this person who's essentially dying in front of you from this MI, and the person in your living room, in your church, and the teeter who just dropped, that's all the things they're going to feel with an MI anyway, and they just won't survive. And it could be this aortic valve regurg. So left ventricular failure is going to put your patient into cardiogenic shock. If the left ventricle is pooping out and cannot function, cannot get the blood out to the body to perfuse the tissues, you're in cardiogenic shock. There's a very high mortality with cardiogenic shock. All right, so chronic aortic valve regurg, not a good thing. You don't want to think that you have it and they're watching it or anything. It's like, when are you going to fix it, is what people should be thinking. They can be asymptomatic for many, many years, but then all of a sudden they're getting huffy. And that's how they describe it. People come in and say, I'm huffy all the time. I'm just, they have to take a breath and exhale heavy. They're huffy. And they'll wake up in the middle of the night, sleeping in bed, fine. They've slept flat with one pillow their whole life. All of a sudden they wake up, they feel short of breath when they're sleeping. Not a good sign to have anything like that at rest, right? It's always worse. People that have angina and it's exertional, they know if they climb a flight of stairs, they'll have chest pain at the top. They know if they have sex, they'll have chest pain. So they pre-medicate before they climb the stairs and they take nitro before they have sex. But somebody who is sleeping and wakes up out of nowhere, it's not good. Just like the person with angina who's in a dead sleep and wakes up with chest pain. When your body is resting and your basal metabolic rate is at its lowest and your body is supposedly recouping and regenerating while you're sleeping, what is causing the strain on your heart to give you chest pain in the middle of the night? So that's the thing here. What's the strain on your heart giving you dyspnea in the middle of the night? So that's not a good thing. Paroxysmal nocturnal dyspnea is not good. Orthopnea, now you hear they're more comfortable with 2 or 3 pillows. Or if I have a patient in the hospital and I'm rounding with a student and they always have the head of the bed up when they're napping or sleeping at night, even in the morning you walk in and they're sound asleep, the head of the bed is up. I always say, did you fall asleep with the head of the bed up, or do you do that? And most times they'll say to me, I do that. And I say, well, how do you sleep at home? Because that, to me, is a piece of assessment data. Whether you're on a cardiac floor or not, why is my patient, 7 o'clock in the morning when I'm in there with a student, why are they sitting in a high floor sleeping? You know, it's one thing if they woke up and they tell me, no, I got up at 5 o'clock, I was watching the news a little bit, and I don't know what happened, I just dozed off. That's different. But the person who does that all night long, a night nurse should be all over that. You know, put the head of the bed down, let your patient sleep. Okay. Now, these patients have a water hammer pulse. So this cracks me up because nobody these days know what a water hammer is. I didn't either, it's before my time. But it's like a seismic kind of a wave, you know? So picture when they tell us more about, you know, God forbid, earthquakes that hit California or somewhere. And they'll say they saw little rumblings and then big, tall rumblings, and then it dissipated off. That's like a water hammer pulse. It's almost like, I've only seen it in cartoons, but I'm sure there's state fairs that have this, where they have those things that you hit with a sledgehammer and it's supposed to go all the way up to the top and ring a bell. After they do that, they whack the bottom thing with a sledgehammer and it goes up and rings the bell. It goes up and down and up and down and up and down and up and down. That's how this pulse is. So it's got all the effort behind it. So it's strong, and then it dissipates, because some blood is still probably getting through, but not enough. So it's a very weird pulse. You'll be listening for this and you'll be like, wow, this must be what she's talking about. The heart sounds are weird. You're going to hear your S1, S2, but then there's others. And if you're going to work in a cardiac area, it is worth you saying to someone who knows better, how does this differ a third from a fourth? How does this differ a second degree murmur from a sixth? You know, so that you get good at them, but you don't need to know them here. Okay, so what do we do for diagnostics? How do we know you have this valvular disease? I'll do this page and I'll let you break. So H&P, a CT of the chest is the gold standard for aortic dysfunction. They need to see right away. They need the nitty gritty. They're going to send you for a CT of the chest and see what's there and then do something about it. You know, they can do echoes. If you're the chronic case and they're following you, they're going to do echoes and see one echo to another, how it's changing. They can do a TEE and go down your esophagus and echo that way. They can do a transthoracic, a TTE, and just do it through skin. They can do the Doppler flow studies. That tells us, you know, venous blood is one color going one way and arterial blood is going the other, and it's color coded. So when there's backsplash, you see the overlap. What else? They can do chest x-ray. EKGs is going to tell us about your dysrhythmias you might be developing. So that's a concern. And they'll probably do cardiac caths and things like that, either pre-op or pre-procedure or post-procedure even. Sometimes they have to do them. So, okay, so take a break. I'll stop recording and we'll come back at the top of the hour. All right, so I'm going to get back to this since it's 1 after. Okay, so we went through the diagnostics. So definitely the EKG, the CT of the chest is your gold standard with aortic dysfunction. You'll see it ordered all the time, but they can do all of these others. They're all pertinent. Okay, so let's look at our collaborative care. What do we do for these people? Well, conservative therapy. If we can treat you, if this is a chronic thing and we can treat you over time, then that's what they'll do. Prevent infection. Don't contaminate people's lines. Why start somebody with an infective endocarditis that could end up with them having valvular problems for the next how many years? I mean, it's a horrible thing to put someone through because someone is sloppy. So be very, very careful of your technique. Prevent infection, prevent recurrent infection. If they have had endocarditis or they have a history of rheumatic fever, we need to get after them about prophylactic treatment. If you're going for dental work, if you're going for colonoscopy because they're over 50 and they're having their routine screen, if they're doing whatever it is they have to have done, have a bone reset, have anything done, get your prophylactic antibiotics. It's worth them being covered than risk getting these infections. It's not. In the meantime, whatever damage they have to their valves, they try and maintain the cardiac output otherwise. So they don't want them to have pulmonary edema or heart failure, so they're probably giving them blood pressure meds, and diuretics, that kind of thing. If they think they're at great risk for clotting and whatnot, then they'll have them on some antiplatelet aggregator. So what other meds can we use? Well, vasodilator is a big one. I talked about nitro, and we talk all about cardiac meds when I do the MI lecture, but what else? Nitroglycerin is one, it will dilate. Nitroprusside, it's also called nipride. If someone comes in who's, malignantly hypertensive, they give them nipride and it drops their BP really, really quickly. So drugs like that. We can give positive inotropes. Positive inotropes are going to increase stimulation, increase the force of contraction. We're talking about digoxin or dopamine or Primacor, or, we'll go through a whole bunch of them in MI lecture. What else? Beta adrenergic blockers. Here we are visiting the beta blocker again. Let's see if we can give a little bit of beta blockade and dull that beta response a little so we don't quickly put them into tachycardia or get some neuroendocrine hormone response. Let's try and control that a little. They'll give them diuretics if they tend to be fluid volume overload. They're not pumping blood well, they can easily start collecting fluid. So they'll give them that, low sodium diets. Remember the anti-coag therapy for people. When they're on it, they have to take it. And if could be something like a baby aspirin today, somebody else a day, somebody else might be on a Plavix, somebody else might be on Coumadin and have to have blood work done frequently. So the teaching depends on what your patient is on. If they have cardiac arrhythmias related to their issues, then they're going to be treating that also. So short term, they may, just put them on medication, and when the infection calms down and the situation calms down, we replace the valve and everything starts working better, they can take them off of it. If it's something that they need to be on something daily, they'll give them amiodarone or procainamide or something, and they'll take something every day to help control arrhythmias. If they need a cardioversion, if they're in AFib and that's rendered too dangerous, then they'll try and cardiovert them and get them out of it. Some people convert well, some people not so good. We had a patient, I don't know, it was last semester, it must be a year ago now. No, we weren't clinical then, probably more than that now, who had cardioversion 6 times. And I said to the student afterwards, I think I would say to them, I don't think cardioversion works on me. I think, really. But they would try them on different meds in the meantime and say, okay, now you've been on that, let's try it again, let's try it again. And, the guy said it was a lot for him because it was anxiety producing. He didn't feel it when they did it because they sedate you, but it's anxiety producing for him to think he's going through it, so. All right, so interventional repair. Well, we have some cool things we can do. Not me, not you, but, some cool things medicine can do. So one of them is a percutaneous transluminal balloon valvuloplasty. And this was really pretty gutsy when they developed this, because when we go into it and I show you pictures, for someone to come up with this idea and say, this will work, I don't know who the first people were that tried it. They had to really be pretty brave. But anyway, it opens up the commissures. Remember, the commissures are the things I told you, the little pieces of leaflet that come together to make a valve close. And sometimes with stenosis, with rheumatic heart disease, they get stenotic and they won't bend, they won't open and do whatever. So they came up with this and they said, what if we take this little balloon thing and we put it through the atrial wall and we get into the left side and we try and stretch these things open and see if that helps. It's a pretty gutsy move, pretty gutsy, but it works. People tried it. I'm sure they did all the testing prior and went through all the trials and whatnot. It was years in coming. But it works. So they do offer to people that they think are a good candidate. And they typically go through the femoral vein. They need a central vein. They can go somewhere else as well, but they typically go that way. They want a big fat one to deal with because they're putting other catheters in. And they put this balloon in and inflate it several times and it opens it up. It's a good option if you're older If you're deemed an otherwise poor surgical risk that maybe you can't withstand open heart surgery to fix this, they can go up through your vein and at least try it. So let's look at a picture of this and see what this looks like. All right, so they're coming up. Here's your vena cava right here. So they're coming up from your groin and come in this way. They're going to take this catheter. Now it looks huge here, and it's sizable enough considering we're breaking through the wall of your atria. You know, it's sizable enough, but it's got a guide wire in it, and they go through the atrial wall like this, which you know causes irritability in the atrium. They're none too happy. And then they get over here, and they have to turn the guide wire and come down here. Now, this is the valve that is the issue that's not working well, that's stenotic. So they turn it, and they come down here. And once they get a position, they use an Inaway balloon over here, which is like a figure 8. It blows up in different sections, and then the whole thing blows up. So they get it in position, and then they start to inflate the balloon. So they first inflate here, and gradually they're just trying to stretch that valve open to see if those commissures will release themselves. Now, to me, that's an enormous gamble for somebody to think of this, because I'm thinking, what makes you think if it's already calcified and stenotic and adherent, it's not just going to tear another way? You could tear the whole valve open, and now you have a patient with no valve at all, and they're not open for us to fix it. This is a closed procedure. So it was pretty dicey. But obviously they know valves better than me because it works. So they put this in here, inflate the bottom balloon, and it's not interfering with blood flow because whatever the valve's doing, it's still trying to do right around the catheter. So they inflate the bottom one, and then they inflate the top one, and they do it very, very slowly. So here it is where it's just in the figure 8, and then over time they keep stretching it and stretching it and stretching it, and then they pull it out. And they find in most people, it will go back. It's enough to tear up that adhesive property between the commissures, and the valve starts working better. And so for those that it works for, it's good. I would imagine if you're the one that's not working so good for, you have an open chest pretty quick, or there's nothing maintaining your blood flow.
Dr. Benetti,
Yeah.
how do they fix the wall and the hole in the wall of the atrius?
Such a small, isn't that a good question? I said the same thing. What they find is that the blood flow comes in and it's all the same coming in the same. It's not like your, like the blood flow coming into the right atria is not getting pushed through that little hole because the impetus is not pushed it that way. And they find that after this catheter is so tiny, now this is blown up considerably, but this catheter is so tiny that as it goes through, we don't open the balloon till the other side. And as it goes through, when you pull it out, it just closes over.
Gotcha. Thank you so much.
Cardiologist, he said if someone needed it, we'd have to put a stitch or something in there. We'd have to. But he said he hasn't seen it, that they just put it through and pull it out. And I'll talk about another procedure where they go up through your ventricle and dilate and everything, and even laser it, and it doesn't leak out. It's kind of unusual. So, but that's a good question. Okay, so here's some other therapies. Now, I have no guarantee this will work. Some days it doesn't. I tried it this morning. It doesn't like to work real well. Let me take it off here. I got to see if I can open this up. The problem is it's an embedded link in Zoom that is in Moodle that is through the internet. So that causes us issues many times. But let me see if I can get it to open. Sometimes persistence is and every time I practice it before, let me see if I get it. If you go on this site, you'll see it opens up to the Sapien site. Let me get it up. Okay, and then you have to scooch down. I think this is gonna work. It didn't work for them yesterday, but I see it working. All right, let me open this up and share screen and see if you can see it. Hold on 1 second. Share screen. Ta-da, can you see that? Yeah, okay.
Yes.
Okay, thank you. All right, so you open up to this site and then you have to scroll down. So if you go looking at and there's all kinds of videos in here if you're interested. These are kind of cool things. But go down here, it shows you different valves. Here is the one you want. And let's see if this will play for you nicely. Can't remember if it has voice. I don't think so. No, I don't think it does. I would be surprised. It's short, it's only 2 minutes or so, but, so here it is coming up through the groin. You see it's tiny. And, oh, they're in the aortic side. And they're coming in. And see the ostia? Look, there's one right there. And there's one on the other side. So they come in here and look it up, make sure heart fibrillates. So they give you some you know, lidocaine, amiodarone, whatever they're going to give you. And they make sure the way is patent. And then they're going to come up, and here comes this catheter. So this is a lot of fishing through. You figure the person who needs this has arteriosclerotic disease. So as you're taking a catheter up like this, you could be knocking it off from all the walls. Look at how they've hooked onto a chordae tendineae here. Do you see what I'm telling you about? You could have a procedure that ruins your valve. I mean, they're hooking on to the mitral valve chordae tendineae to hold this down. So they're coming up here. There's your ostia. And they're coming up here and turning the corner. So this side, they didn't have to go through the atria because they came through the aortic side, but there's risk coming through the aorta too, you know, and they come down in position. Oops, where did it go? And they just slowly inflate it. I have to get it just so. Yeah, it looks like a crummy valve. Ooh, they're fibrillating just a little bit. But here they're putting the valve in. So this is your valve replacement. Now they'll take this out, and do they show us coming to get the guide wire? They might not show you how they have to unhook that guide wire and hope they don't rip that papillary muscle. No, just magically the guide wire is gone maybe, huh? Oh, magically it unhooked itself. So, all right, so that's a valve replacement that they can do without major intervention. And look at it now, works good. And there's your ostia, see them both sides? One there and one there. Okay, so you can look at that if you need to. All right, let me go back and find your PowerPoint. And see where we are. Oh, this isn't good. Here we go. Slideshow setup. Yes. And okay, can you see that now?
Yes.
Yes.
All right, I just want to be sure you could see it. All right, so that worked pretty good. I'll have to give them feedback. We probably have no idea why it works. Sometimes it does not. Okay, so those are things they can do. This is the alternative to do a non-invasive aortic valve replacement. So, all right, so otherwise they can do repairs, they can do replacements. If they're trying to do repairs, they're not always as effective. They might buy the person some time for what they need, but they're not as comprehensive, as long-lasting as somebody having a complete repair. All right, so what else can they do for valve repair? Well, mitral commissurotomies. If we know the commissures get stenotic, they can go in and open up your heart, put you on bypass, do the whole thing, and go in and slice between the different valve flaps and break up those commissures. That's one way of doing it. It's, you know, they can get in there and take out clots and do whatever else they have to do, but they can do that. They can do a closed procedure. I have pictures of this for you. This is a little less precise. This one, they use a transventricular dilator. So they go up through the apex of your heart, and they bring this dilator all the way up and stretch open your aortic valve. Yeah, it's a little dicey. That one, they go in through the bottom, and usually they have to stitch that at the bottom. And your ventricle is not too thrilled about being stitched upon, so your patient can have arrhythmias from that. Then they do just open commissurotomies where they're going to put you on bypass and do all of that and go in and take out clots and clean up debris. And, you know, if you have vegetation, old vegetation in there, they can really do a lot of cleaning and check out your chordae tendineae and your papillary muscles and see how everything is, and they can clean up a lot. But it's a big open heart surgery. You know, it's not a small repair. Okay, so here's your different valvulotomies, and this is like your annuloplasty here, if you're gonna just replace the ring. So maybe this is all ratted and not doing well, and they'll just come in and replace the ring. This is your dilator. Now this thing looks huge, and it looks really cumbersome. It's very, very, very tiny, very thin. And this is what they will put through the apex of the ventricle and push up into your aortic valve. And then they open these wings right here. It goes in a straight piece. And then they open these wings and it pulls open all the commissures and tries to get the valve working. This is your commissurotomy, that you're having stenosis because you have all this adhesion and all of that. And they'll come in and just separate these valves and make sure that scar tissue's gone away. Some people do well with it. Some people, after it's been stenotic, they clear it out and now it's regurgitative. It doesn't work as well. So we're always assessing afterwards because we're never sure it's working until we see how they're doing, you know? Okay, so minimally invasive valvuloplasties are getting really popular. And a lot of people, if you're a candidate for it, it's better. It's not a complete open sternotomy in that they're cutting you down the middle and prying open your ribs and putting on bypass and you have this big, miserable, extensive surgery. It's no joke, but it's less than it was. So they do a mini sternotomy. They take out a little piece of your sternum proximal to where they need to get to, and they use robotic systems. Now they still have to put you on bypass machine. So you're on cardiopulmonary bypass, which a lot of problems people have post-operatively is related to that whole cardiopulmonary bypass, that they've taken your blood out and diverted it and oxygenated it and separated clots and done whatever, and it's affected you. So they say the outcomes are pretty much the same, but it's still less invasive. They do have to pop your lung because they can't get in there to work on your heart with this big inflated balloon. So they have to deflate your lungs. You have chest tubes. And it's less risky than doing a full open sternotomy and open your ribs, and the healing is less time, it's a shorter stay, but it's a possibility. And a lot of times you don't drive that truck. The doctor can tell you what you can withstand. And then the annuloplasty is the picture I showed you. It just replaces the ring. It's a lot to go through to have an open surgery just to replace the ring. Everybody's different and everyone weighs their options, but I think if I was having them go in and do all that, I'd have them repair the valve. God forbid I had a valve problem. So valve replacement, well, we can do it. We do them all the time. They're really pretty perfected. They do well. We do them for mitral, aortic, tricuspid valves. The primary treatment for aortic stenosis, your patient, and regurg, your patient needs to have that aortic valve fixed. Even the 90-year-old lady from church. If they're gonna live, they have to have it done. So the goal is every time they're evolving a new type of artificial valve, they need it to be non-thrombogenic, so it's not gonna collect clots because it's a foreign thing in the body. So it's primed for collecting fibrin and platelets and all of that. It's a nutritive area. We want it durable. It's gotta last you. Because now kids, we understand, you have a valve replacement at 3, you're going to have the valve change growing up because your body's growing, your heart's growing, everything, it's not going to meet the needs. They'll have to have recurrent surgeries. But adults, we should be able to give you one and have it last you. So that's what they're looking for, something that's durable. So we can do mechanical valves. They're good. They're metal, they're pyrolytic carbon, they're Dacron, that's synthetic polyester, the Dacron from polyesters. That's what it is. We can do biological. We can give you a human valve if somebody has died and you need it and you're at a center where they do that, they'll transfer a human valve in you and see if that works. Small window that you can deal with that, but they can give it to you. Bovine, that's from your cows. Porcine, that's from your pigs. Those work too. And, there's usually some man-made piece involved in pulling this tissue together, but it's not a completely artificial valve. So let's look at a few of these. Oh, it's the next slide. Okay, the mechanicals last longer, but they can cause clots. Now, as long as we've been working on them, they're trying to get them so they are non-thrombogenic. But you're trying to get the body to say, oh yeah, this new shiny valve that's in there, it's one of us. It's been a part of us all the time. And because it's healing tissue, the body's going to send fibrin, it's going to send plasma and everything else to it. So, you know, the chances are you can have issues with it. So they have to put you on anticoagulants. So that increases your risk of bleeding, obviously, because you're going to have to stay on them. Now, it's better for young people because long-term, the valve lasts longer. So if you're in your 30s, a mechanical valve is going to last you. It's not like it breaks down and you have to go in and like a flat tire and get it changed. It's going to last. It's mechanical, it's simple, and it'll just keep working. But you have to stay on these therapies that you're not going to clot and have issues with it. Now, the biological valves do not need long-term anticoag therapy. Probably for surgery, they will. They'll, you know, like we treat a surgical patient and we give them Lovenox or whatever, we'll keep you on something for a little bit, but within a couple of weeks, they are no longer on anticoags. So the problem is being normal tissue, whether it's cow or pig or human, it's prone to aging like every normal tissue, like the cow, like the pig, like the human. So it does have a tendency to calcify over time. It can stiffen, it can do the same things that cause this person to have an issue with their own valve can happen in this animal or human valve. So that's the thing, we don't have a clear enough crystal ball to know how long it's gonna last you. Now, it's good for someone who cannot take anticoagulants. If you have somebody who has HIT, if they have heparin-induced thrombocytopenia, which means they develop this big problem, it's they think autoimmune, and that's your response to being exposed to heparin, you would rather be on the therapy that you don't have to have. Even if you're 30, you'll have a valve change down the road before they're going to put you on something that you have to be on an anticoag, and it's going to start this whole cascade of problems. So it is good for people like that who have HIT, but people over 65 typically, who it'll probably be durable, it's new to them, it's a valve in good shape or we wouldn't use it, and you know, it's the lasting through their lifetime and their lifespan is more important than the anticoag risk to them. You're going to have another person over 65 if you have them with a mechanical valve, that they're over 65 and they're on long-term anticoags, that you know they fall, the biggest trauma is they'll bleed into their head. So it's a risk-benefit ratio. And it's not up to us, but it's up to us to understand why they're picking one over another for the patient. Okay, so let's see. Here's some valve. I'm sorry. Janie MC Kleski forgets that I teach when she doesn't. So here's the type of valve. So here's a tissue valve. This has been around since God was young. This is all Dacron here. It's all pyrolytic carbon underneath. And it's one of the early ones. The ones now don't even have the metal underneath. They're just animal valves, but these are different ones here. This is the St. Jude bivalve. And this is very popular too. And it just opens and closes. You see how simple it is? It's just a flutter valve. Open and close, works well, doesn't take up a lot of space. You know, people have good luck with it. This Star Edwards, now this is the ball and cage. And Star Edwards has a great valve. It's got great results, but it clicks. It clicks, I'm telling you, it clicks. So this ball, when the blood is flowing, goes here and stops in that circle. It can't go through it, it's not big enough. So it stops, and then blood flows, and it drops, and it has to close, and it comes back up. And it works real well, but it has a click. And they've gotten better over time that it's a little less. But when I first had patients in cardiac care units, and they would have these, they told them ahead of time, this will click. It's like an annoying clock that ticks in your room at night, that tick, tick, tick. And sometimes you'll walk into a room at night and the patient's sleeping and everything's quiet. You can hear it from the bottom of the bed. You hear that click, click, click. You could take their pulse listening to the click of this Star Edwards valve. I mean, it's crazy. And every once in a while, the patient would come off of all the equipment, coming out of the ICU, and they'd be like, do you hear a clicking noise? And you don't want to tell them, yeah, that would be you the rest of your life now. This is the clicking that you've heard them tell you about, but it's that kind of a click. So they're very much aware of it. But it works, it's, you know, and if they've tried another valve and had issues and something didn't work or it didn't take or something, they may go to it. And like I say, Star Edwards has worked on it over the years, and they have multiple variant valves, so they can have better ones all the time. So here's a core valve. This is minimally invasive, the one you saw, and it will always have some piece of metal. This is a metal cage, the same kind of stuff they use when they do stenting in the heart. And it's a little metal cage, and this is like a big valve in here. So they can do it minimally invasively. They put it up, they open that cage, it digs into the vessel, and then the valve is there working. And they do well. It's a good one. Okay, so what else about valves? Both of them can cause leaks. Both of them can cause endocarditis. Because what's the deal? You're putting something foreign in the body. We've had intrusion through the skin. They're either opening you up and doing it, or they're going up your groin and your radial. They're going somewhere in the body with a non-invasive line. And if they're bringing any bacteria with them, there it is. And it's got the perfect environment. And now that you're healing from this valve, you have a lot of collagen, you have fibrin, you have everything there trying to help you heal. And it's just what bacteria is going to want to glom onto. So be very careful in your care of people. Don't be sloppy and infect them. It can be done minimally invasive, which people buy into it easier. Not that they won't have to have a procedure, not that they're not afraid, but it's better than having their whole chest cracked open. That's a big thing. The anti-coag therapy, even with the tissue valves, you know, the pig or the cow or the human, you'll be on anti-coags a little bit, but then you're off. And that's good long-term for some people. So that's just, if they have chronic AFib, they'll be on some kind of anti-coag or something going forward because of the risk of plaque. So what is the goal here? They're trying to normalize the cardiac function. We can't have it that the blood flow is not unidirectional and that it's not a set amount in each chamber. We have to maximize cardiac output. So let's get normal cardiac function, get them to have improved activity and tolerance. They don't know what it is. These people are orthopnics, sitting with the head of the bed up, sleeping that way. They don't know what it is to walk around and not be short of breath. You know, so we're trying to clean up all of that. But they have to understand this is not a cure. This is a replacement. And it requires them to be invested and do follow-ups and be careful in their own behaviors. Okay, so what do? Prevent infection in your patients. Start there. Please God, there's never been somebody that I've contaminated that God forbid got one of these infections. But you have to be that diligent that you're not exposing people to the possibility. Pre-intervention, we restrict activities in these patients, anything that increases fatigue and dyspnea, anything. So they don't like, and people tell you, I feel like I'm a cardiac cripple. My grandmother was like this years ago. And it's not that they're a cardiac cripple. It's that let's understand the impact. The heart is doing what it can to get you through your valve malfunction. And we're trying to do what we can to get you through to be healthy in surgery and get this fixed. So, you know, this is frustrating for you. You probably ran a company or ran a marathon or whatever you did, and this is a big change in your behavior. But for now, it's necessary. Let's try and restore you as best we can. Get your quality of life back. Post-intervention, if they're on anti-coag therapy, you have to beat compliance. You really have to go after it. Frequent INRs, they're going to have. They want them to stay with valves 2.5 to 3.5, and that's therapeutic for a mechanical valve. So they got to be careful. Don't be climbing trees and run the risk of falling. Don't be jumping out of planes. You know, there's some things you might have to control and curtail in your life. Valve replacement and repair is not a cure, not a cure. It takes a lot of ongoing care. If what was at the base of this was not, say, a rheumatic disease, if it was an endocarditis, they have to be very careful of being exposed to infection. If it was rheumatic disease that started this, rheumatic fever or whatever, then they feel sick, they have to be cultured. They have to get in and get treated for this. Not that we want them on antibiotics for nothing, but if they culture your throat and you have strep, you have to have it taken care of. You've already shown by history, you're the one that has the aberrant reaction and ends up with rheumatic heart disease. So we have to control that. Okay, So here's some cardiomyopathy. Not too good. This is not a good thing. I don't teach, well, none of cardiac disease is good. So cardiomyopathy, this is a disease of the heart muscle. And so that if you have a disease of the heart muscle, it's going to impair the function. So the treatment is palliative. We have no cure for cardiomyopathy. Even a transplant to give you another heart is not a cure. That's a whole nother set of circumstances come with that for you to maintain it. So it's a challenging situation. Primary is the heart itself, and they usually don't know. All of a sudden, you're a perfectly healthy person and your muscle's failing. What's happening there? And sometimes they don't know. They just say, wow, you don't have any of these other things that cause it. What happened? So it's just the way it happened. And that happens to people. It's not a large number of people, but you do see it. It's most unfortunate. So secondary is that you're alcoholic or a drug abuser, or you've had chemo. These poor souls that you have this horrible diagnosis of cancer, you're doing what you can to live, you take chemotherapy, and it gives you cardiomyopathy. And now you live with an ailing heart, you know. It's a horrible hand some people are dealt, but chemo for sure can do it, which is why most times before you start chemo, if it's one that can affect, if they're going to use chemicals that can affect your heart muscle, they do the MUGA scans first. They do the multiple gated acquisition studies of your heart to test your muscle, to have a baseline, and then they do it periodically to see what the chemo is doing to you. Hypertension can do it. Long-standing, untreated hypertension can give you a left ventricular failure. And the muscle gets really, really thick with an LVH. And the heart otherwise looks normal and the LVH is huge. You see it on a chest x-ray, you're like, wow. And the rhythms change and all of that, so you see that. But that's someone who has hypertension and either won't comply with treatment or won't seek it. It's one of the things that happen. An MI can cause you cardiomyopathy because it's going to infarct a wall of your heart, sometimes two walls of your heart. And now it renders your muscle not to work. So that's cardiomyopathy. You know, you're left with a muscle that doesn't really pump well, doesn't work well. Pregnancy can do it. Not your, mother who has a single carry or maybe twins, but we're talking like your Octomom or who's the family on TV, you know, they have 5 or 6 babies that they carried at one time. Something like that puts the mother at risk for sure. And that's one of the things, most of them are on bed rest for quite a bit of time. You probably learned in maternity. But it definitely puts a strain on the heart and all of that. It's not your normal pregnancy that somebody would have. It's really taxing with the extra fluid volume and all. Valve disease can certainly do it. Again, we're back to radiation. You've had a breast cancer, you've had your chemo, now they're doing adjuvant radiation therapy to you. It's zapping your chest, yes, but the collateral damage is it's hitting your heart. Maybe the effect it has. Maybe it's your esophageal cancer. Maybe it's your stage 4 cancer that's into your sternum and they have to zap your sternum and that's what's happening. So that's something we can't control. And we don't know if you'll have it. Plenty of people have radiation and don't have it, but it's one of the causes. Or amyloidosis. If you have a situation like that where this abnormal protein that should be in your bone is now depositing everywhere, one of the places unfortunately deposits is in your heart muscle. So if you have amyloidosis, we know you have a chance for cardiomyopathy. Okay, so here we're looking at the types. So this gives you a little visual. Here's your normal heart and systole and your normal heart and diastole. And they don't look too much different, but this one is contracted. Systole is pushing the blood out, and diastole is filling up. But then we'll talk about a dilated cardiomyopathy. So the heart just dilates out and it gets real big on the outside. We'll talk about restrictive, that gets real rigid, that you can't pump well. And we talk about hypertrophic, where the muscles get real thick on the septal wall and on the exterior ventricular wall. Takotsubo is a newer, maybe 20 years, 25 years maybe, cardiomyopathic term they throw around, and it's named for the guy who picked it up. And he found that people who experience horrible grief or some major event in their lives can go through what appears to be a cardiomyopathic episode, but it resolves after they're over the trauma or the death or whatever they're experiencing, the tragedy. So that's Takotsubo's. It's rare, you don't see it, but it is an accepted phenomenon worldwide. Okay, so here's your dilated. Now this poor soul is obviously dead for us to see the cross section of their heart, but it's a good picture. Not only do you see a lot of fatty deposits everywhere here, but you see how dilated this muscle becomes. You can see why it becomes useless. What happens here is it dilates, it just expands on its own. So when it tries to contract, it comes back some, but it's limited. You know, it should be able to come all the way back and push the blood out. But it has dilated so much that even when it contracts, it's not enough. It's not functional. So this is a bad one. These people don't do well. It's not good. It's heart failure in all your cardiomyopathies. Heart failure is just, it comes part and parcel with cardiomyopathy. The heart's not beating well. The fluid has to go somewhere if it's not going forward. So it backs up to the lung and the patient is symptomatic. Here we see it, middle-aged African-American men, and they think that it's related to the increase of hypertension in that demographic group. Men in general have more than women. Alcoholics have it. They feel there's some kind of genetic link, something that comes genetically. They just can't identify it. But it's it's consistent in families that have it, that they can't believe there's not a genetic link. It can be the myocarditis. Not everyone gets myocarditis, but your rheumatoids will. So if they've had myocarditis, the muscle is affected, right? And it gets deposits in it and fibrin deposits, and it doesn't function well, and it's been inflamed, and it will just get to the point where it almost says uncle, and it dilates, and it's really not well functioning. So it can certainly be a rheumatoid people. They do see a higher incidence in autoimmunity as well. So remember what I've told you, someone has one autoimmune disease, chances are they'll have another. You have one immune system. And if it's acting aberrantly already to one organ or one system of your body, it can certainly do the same in other systems. All right, so dilated and hypertrophied can look similar on the outside in that they're enlarged, but the difference is on the inside. So I stop here to point that out. Here's your dilated. So everything here dilates, and it tries to come back to contract, and it just can't come in close enough because the muscle is no more elastic like it needs to be. So it just doesn't do well. It's just dilated and doesn't contract well. Here, this is big on the outside for sure, but in a hypertrophied cardiomyopathy, look at how hypertrophic the left ventricle is. It gets so thick, so does the septal wall, that it's hypertrophied that you see on the inside. The outside is big like the dilated, but the inside is the difference. So that's a good depiction of that really. But on an x-ray, the shadow of them on the outside can look the same. The devil's on the details on the inside. So that's the problem there. Okay, so what happens with dilated? This is diffuse inflammation that causes degeneration of those muscle fibers. So it impairs the systolic function because there's such poor contractility. It has expanded, but it can't come back. It can't come back equal to the way it's expanded. So it's pumping, but it's not moving. It's not doing enough to move blood forward. You have stasis of blood in a dilated cardiomyopathy. The sudden cardiac death comes from these ventricular arrhythmias. The ventricle gets testy. It's dilated. It's got pressure for blood. It's supposed to move blood. It's moving and it's not effective. And you have ventricular enlargement. You have atrial enlargement. This patient usually will have a lot of ventricular arrhythmias because the muscle is so stretched. And often that's what takes them out. But the heart failure is terrible too. They just can't move the blood. So what else? What do we see when we see somebody with this? Well, you can imagine decreased exercise capacity. They're huffing and puffing. A flight of stairs kills them. They're fatigued. They're short of breath even at rest because the disease isn't exercise dependent. The heart is dilated and can't pump enough to move the blood, whether you're sitting, standing, moving, laying down. It's just not working. So they're orthopnic, they have palpitations from the stretching of the atria. They have that dry cardiac cough, that constant all the time. They don't want to eat and drink because they can't breathe well. They're tired, they don't have the effort. They just aren't interested. They have irregular heart rates. They can have atrial arrhythmias because the atria is stretched. They can have ventricular arrhythmias because that's where the disease lies, is in the myocardial muscle, and the ventricle is going to feel it significantly. So they have arrhythmias, they have extra heart sounds, hepatomegaly, JVD. It's because the left side, the heart is dilated. It's created a left-sided problem that can't be fixed. It goes all the way around to the right side. So you see the JVD, you hear the crackles from the engorgement in the lung, you see the hepatomegaly, and it'll go all the way around. And by then the patient's usually moribund, they're gonna die. So they can die of arrhythmias, they can have clots because they have stasis of blood trapped in that ventricle. And if it's sitting there and it's clotting, if something dislodges, they're dead. It's usually a big enough clot that that's what does it. Such a sad state of affairs to see someone like that diagnosed with that. All right, so what do? H&P, you're gonna rule out other diseases. Let's do an echo. Let's see what the heart looks like. Chest x-ray is showing you a big round heart, which could be hypertrophied. It could be dilated. It depends on what's on the inside. So they gotta look at an echo. EKG is gonna tell you they'll have atrial arrhythmias, they'll have ventricular arrhythmias, maybe both. Labs, we look at BNPs, the beta natriuretic peptide. This is something that's released from your right atrium when there's pressure changes coming in and out of the heart. So if your BNP is high, your heart failure patients get this drawn all the time. So it's something that, we're constantly checking for. They can do a cardiac cath. They can do a MUGA scan, a multiple gated acquisition, to see in each compartment how the blood flow is, what's the ability to receive and move blood and all of that. They certainly do it before they begin chemo that is cardiogenic, cardiotoxic, because they want to compare your earlier one after you've been on chemo treatment for a while. But they can do it to chart progression of your dilated, how bad you're getting. They can do endomyocardial biopsies. Maybe they just want to see what the etiology of your dilated is. So they want to go in and see, is it autoimmune? Is it that you have deposits in your muscle from your rheumatoid disease? Whatever. They want to know the etiology. So they can go in there and look. Take a little snip of tissue. All right, so what do? Well, these patients don't do well. Cardiomyopathic patients in general don't do well. They have bouts and bouts and bouts of heart failure. They will have all kinds of arrhythmias. So you teach compliance with the medications. They have to stay within the rigor of activity that is allowed and what isn't. They have to adhere to a diet. They're not happy. They know they have a bad heart disease. It's very hard for them. They'll give them nitrates for vasodilation. They can give them loop diuretics if they think they have too much fluid on board coming in the preload, coming into the heart. They can give them the nitrates and give them some diuretics. If the kidneys are still working, they'll respond. If they don't have another comorbidity, they'll respond and take some fluid off. But then they have to stay off the salt also. ACE inhibitors help with afterload. We've talked about the renin-angiotensin-aldosterone system and how angiotensin 1 normally converts with ACE enzyme to angiotensin 2, which is a potent vasoconstrictor. If we interfere with an ACE inhibitor and we don't allow that, we don't allow angiotensin 1 to convert to angiotensin 2, it causes dilation. So that reduces the systemic pressure of blood getting out of the heart. So it's going to decrease that pressure that the heart has to overcome to get blood out. So in a failing heart, that's helpful. We're dilating vessels so that as the blood is pumping, there's less resistance to get it out of the aorta and into the body. We can give you spironolactone for any neural hormonal stimulation you have. It really works anti-aldosterone because it's K-sparing and it's still a diuretic, so it's going to work to help with that. The anti-coag therapy is important, but they also have to understand, you know, being careful to not fall and things that are going to cause them to bleed, things to watch out for. And the statins, we can't forget if underlying this patient has high lipids, atherosclerotic plaque, and all of that, they have to be on some kind of statin. Now that's just adding to the problem, you know. Okay, what else can be done? We'll do this one, maybe I'll let you go. Oh, there's a goal of treatment after this. Maybe we'll do this one. All right, so what can be done? Goals of treatment. Let's control the symptoms. Let's try and do what we can to control the heart failure. We're trying to improve the cardiac output, improve the quality of life. They might need a ventricular assist device. That ventricle might not be able to pump enough on its own that they need something mechanical to do that for them. So they could put a ventricular assist device in there. They could put this up here, this intercardiac defibrillator. So this will get threaded in, and if you go into a lethal arrhythmia, it kicks in and defibrillates for you. Now, people who have lived through it are like, okay, you can take that thing out. I don't want to have that happen again. I mean, when it goes off, they feel it. It's not very comfortable if they're conscious still. This is on the outside of the body. This guy, you can see all of this here, but he has skin over this. Students always ask me this. It's, I guess, a confusing picture. You don't see any of this. What's outside the body is from here out, the little battery pack and the harness they wear. But this is just to let you see what's happening under the skin. So what happens? They take one end of a pump and they put it in the bottom of your ventricle, which your ventricle is none too happy to have done. But if you survive that, you know, they try and control the arrhythmias and whatnot. They put this in this end, it goes through a pump. So now your blood is coming from the lung into your left atria, comes down in here, goes into the pump, gets processed, bypasses all the way around, and we stick it into your aorta. So we're bypassing all of this in here. And it's because your myocardium isn't working, so it can't pump it on its own. So that's what we're doing. It's good for people waiting on a transplant. You'll find that transplant centers like Maine will put people on them because they're hoping to have a heart to transplant into them. The thing is, 50% of transplants are done for cardiomyopathy, and there's not a lot of hearts to be had. There's just not. So you have to be well enough to tolerate the surgery for this and well enough to tolerate the possibility of being a heart transplant patient, which is no easy feat. So unfortunately, what you find is people go for this because if they don't, they're going to die. And, you know, hope springs eternal. Everyone tries to be hopeful. They want to live. So they can put this in, but if a transplant isn't coming your way, or you keep getting knocked off the list for infection or for one problem after another, you can stay on this for a long time. And eventually people will have an LVAD and a right side. They'll have an RVAD as well. And then you're just kind of chronic and you're there until they shut the machine, basically. So if you don't get a transplant. All right, so that might be enough gloom and doom for today. It's 1:50 and you have a nice weekend, and we'll pick up with this next week. If you have any questions, text me. Let me know what your questions are and I'll help you. And you should have some fun tomorrow. When's Valentine's Day? Sunday? Sunday. So everybody find a Valentine and go have some fun, okay? All right, guys, thanks for your attention.